Hey guys, ugh, I don't necessarily like this video this big, but we're gonna get started. I'm gonna go over some diabetes medications first. So just hold on. Okay, diabetes medications, they're typically used when the body no longer creates insulin or not enough, or for type 2 diabetes, if over time, either from weight or diet, people are now needing medication or insulin to uptake glucose, whereas type 1, the young kids that have it from childhood on up, it is from birth. You can't really get rid of it, but you can treat it with exercise and diet. So let's talk about diabetes meds. One of the first things you hear about when you talk about diabetes medications is the A1C. I'm going to hide my picture because I don't need to be here. A1C, usually it's the best way for people to assess how somebody's glucose has been running for the past 3 months or so. Red blood cells are freely permeable to glucose molecules, and what happens, the red blood cells have a lifespan of about 120 days. So they look at the glycated hemoglobin reflects glucose levels over 2 to 3 months. So you have those people who come in and they've been trying to eat real good for the last week or so, and their glucose numbers, their fasting blood sugars, their sugars are fine, their glucoses are fine. Getting the A1C tells you what they've truly been running. That's for a new onset diabetic or somebody who's not been compliant, but just to help someone realize that their lifestyle isn't working as well. So the big thing is that A1C of greater than or equal to 6.5 is diagnostic of diabetes. If confirmed by repeating the test, usually you'll do more than one test. Uh, that's one of the big things with the glycosated. So remember, 3 to 4 months is what we look at for the hemoglobin, A1C. Some of the things is this is a quick chart you can look at. Action suggested if they're greater than 10, and that can vary depending on your source. Glucose averaging 275 if you're looking at that. So you definitely want to do some intervention. Excellent 6 or below a 6, usually their glucoses are maintained, so they're not really worried about those. There again, you can look at various sources, but usually when you look for testing questions, those numbers are way out. They're not looking at 6.5, 7, they're looking at 8s, 9s, 10s. They definitely tell you the A1C is elevated. So you should be ready to consider treating that patient, okay? So glucagon. Glucagon is one of the first things. It's administered IV, IM, or sub-Q. It is a hormone. People think it's a lot of sugar, but it's actually not. It's a hormone that causes the body to release glucose into the bloodstream. It affects the liver, causes it to release that glucose. Sometimes you have that side effect. They have headache and nausea, drug interactions. Glucagon can interact with oral anticoagulants. So if they're taking anything to aid in bleeding, like Coumadin, uh, you may see, or heparin, you may see an alteration, increasing tendency to bleed there. So you will watch their bleeding times. Glucagon is typically given when somebody's glucose drops and we don't have IV access or can't get it. We need to rapidly bring that glucose up. And sometimes you'll hear them saying 1 amp of glucagon. So let's go to the next screen. Insulin and propranolol, and they shouldn't be given together. They're high risk of interactions. Which insulins can you give IV? The only one you can give IV is regular. This is just adjunct to your notes you already have, okay, guys? Um, Replicolide, Prandin, dietary concern, no grapefruit or grapefruit juice with this one. Diabetic ketoacidosis, this is when somebody is onset 4 to 10 hours lack of insulin, so the body's not getting enough insulin release, so they're not uptaking glucose. So then you have fruity smelling breath, you have cool small respirations, thirsty, dehydration. They have tachycardia, elevated heart rate, low blood pressure. The heart rate increases trying to perfuse while the blood pressure is dropping. They become acidotic because all that glucose is building up. So you'll see them breathing faster. Their breath smells sort of fruity. When you think about all that glucose is building up in your system, it makes sense. You have hyperkalemia, elevated potassium, and polyuria, frequent urination. Because what is the body doing? Your body's trying to urinate to get rid of what? That extra glucose. So with this, usually you're going to have hydration, insulin, electrolytes replacements. Insulin is injectable, sub-Q immediately prior to meals, typically how you give it. It says for hypoglycemia. So for Similac, it's going to be very important to look 30 minutes after the initial dose to see what their glucose is doing. You cannot mix Similac with any other insulin. It can be administered at the same time at separate sites, though. Creates satiety, a sense of fullness or sensation of not needing anything. Decreases production of glucose by the liver, so the body's not kicking out more glucose into the system, and it drops the need or the hunger. Slows progression of food to decrease uptake. Only given when other options have been unsuccessful. Big things, you can have lipodystrophy. You should be talking about this in your nursing foundations class. Lipohypertrophy and lipoatrophy. Lipohypertrophy is when the patient has a rubbery texture to their skin. And you'll see how it starts to dent down, and you shouldn't inject into those areas because it doesn't absorb well. So physically, skin on examination, you should look for evidence of both, because it will decrease absorption and you'll see the patient having increased glucose comparison. Some of the big things we need to know when you talk about diabetes in general: hypoglycemia, sweating, pallor, irritability, hunger, lack of coordination, sleepiness. Where hyper or elevated, you have dry mouth, increased thirst, weakness, headache, blurred vision, frequent urination. So dry for hyperglycemia: hot, thirsty, weak, tired. Think about those things. Headache when you get too hot. Hypoglycemia, you get pale, you don't have enough fuel to get you going, so you have lack of coordination, you're sleepy, you're tired, irritable, hungry, hangry as we like to say, sweating, and pallor. It helps you decide which medications to give. Comparisons, remember, these are subjective versus objective roles. You can actually copy those. You can copy these links. I'm not going to run them for you. You can look at them. That's why I'm holding them here. You can copy them, take a picture of it, and you can watch the videos that go into the roles of insulin if you would like. It's not required. So sulfonylureas, betas, pancreatic farm. You should monitor for hypoglycemia with these. Avoid during pregnancy and lactation, that's breastfeeding. Avoid alcohol use with them. These drugs are indicated only for type 2 diabetes, so you should never give sulfonylureas to type 1 diabetics. Okay, you should never give these to type 1 diabetics, or the pregnant mom, or those who are having babies and they shouldn't drink what? Alcohol. Amaryl and glipizide, glucotrol, they release insulin from the beta cells. The pancreatic beta cell detention center for type 2 diabetes. It makes sense to check blood glucose levels before dosing. You should always check the glucose before you give the medication, and watch for signs for glycemia while using these drugs. While on them, you can watch for headaches, weakness, dizziness, and drowsiness with your client. Metformin or glucophage, the inspector, metformin, we like this one. My team is here to help control blood glucose up close. They're again in type 2 diabetes. They help slow down glucose production in the liver. They need to block the absorption of sugars into the intestines. Metformin helps the muscles use the sugar more effectively. Dogs and cats can get diabetes. We need to pause for control. Uh, everyone is after a little sugar. Metformin can be used with other hypoglycemics, so you can use those with others. That's the big thing with metformin. Glucagon, we already talked about that. It's when sugar's gone. Get it? Glucagon, when sugar's gone, you give this. It is preferred IV if at all possible, but if they don't have an IV, there again, you can do an IM, sub-Q, or IV, or IM. Brain candy cool. The brain uses more glucose than any other part of the body. That's why you see the dizziness and the lethargy and confusion and instability when their glucose drops very low. Mixing insulin. Some of the big things you need to remember: you draw up the clear first and then cloudy. Clear and fast acting go together. Clear, regular, less pro, aspart, gilson before the cloudy. NPH cloudy and long acting. Only longer acting you can mix. Okay, NPH is the only long acting insulin you can mix right now. Prevent contaminating a short acting insulin with a long acting insulin. You always draw up the regular, clear, short acting before you do the long acting. Types of insulin. This is a good picture for you guys. Onset and peak. If you look, it shows you got less pro, 15 to 30 minutes when you start seeing it occur. I start rapidly and peak at a half hour to 2.5 hours. Then right behind it, you have regular insulin, 30 to 60 minutes, and it lasts, and the peak in 1 to 2 hours. Start fairly fast and peak in 1 to 5 hours, which is followed by NPH. Start slowly and peak 6 to 14 hours later. Then you have Lantus. Lantus is the long-acting background. It's there for the long haul. It really doesn't have a peak. It just acts like the body's normal system of releasing a little bit of insulin throughout the day. So that would be a one-time dose typically, whereas the regular or your Lispro will be to treat immediate glucose levels, like with a sliding scale. You do need to be aware of the time of the onset and peak, so you would know when to reassess the patient, because you assess to treat initially, and then you have to reassess to see if the medication is working, and you have to know when to look for possible hypoglycemia. Rapid acting insulin, remember, due to its rapid onset, you need to have food ready or ingesting when using Humalog or Humulin R. You need to have those right there. Otherwise, you could drop their glucose. Regular insulin can be mixed with all insulins. Lispro can only mix with NPH Lent and Ultralent. So you do really need to remember that. Regular can be mixed with all insulins. Lispro can only mix with NPH Lent and Ultralent. All three rapid acting insulin, Lispro, Asparta, Glucagon, and regular can be given IV. All of your rapid acting. First place, fast, rapid acting, Humalog, Lispro. There again, you see the numbers again. Always remember that a person should know sliding scale and know how to check their glucose. And a lot of times they'll do treating depending on their glucose. That's when you see the charts that say if your glucose is this, then you give so many units, and make sure the patient does not mix up the long acting versus the short acting. My insulin needs will drop in the first trimester. Do remember insulin rate requirements during pregnancy. A lot of times at the beginning of pregnancy, they may not need as much glucose. So the mom, if she's pregnant, should really be monitoring herself, because there may be a decrease in her insulin needs if she is diabetic as she goes into her second and early third trimester. She needs to be considered, because she may need an increase in insulin this part because of hormonal changes. But then as she gets ready to deliver or delivers, she will start to drop back and stabilize. So this is a sort of volatile time that she should be doing close checks on her glucose, because early on, first trimester, the baby's using all the glucose. Then as she gets further on, she may need an increase in insulin due to hormonal changes. Then she'll stabilize after delivery. So those are some of the key things you do need to know about diabetes and insulin. I just wanted to share them with you. Let me go back. There's a chart I wanted you guys to see. Remember, familiarize yourself with A1C, what it is, and you should be getting that in foundations. But you also, some of the big things I want you to remember, regular insulins are the one that you can run by IV. We don't do long-acting insulins, and if they are doing short-acting insulins IV, you're doing frequent glucometer checks. Typically, they're in intensive care, and they're doing glucometer checks anywhere from every hour to 30 minutes, depending on the patient. Okay, so please review the various types of medications you give. Remember, Similac, the big thing I want you to remember, you can give it immediately after meals, preferred with the first bite, as hypoglycemia is likely within 30 minutes. So you need to have their tray. You need to make sure they're not nauseated, that everything they need is available to eat, and that they are ready to eat, that the food is something they can't eat. If they're, say, Muslim and they don't eat pork, you need to know that before their tray comes. You can't say the tray is on the way and have verified that it is something they can eat. Also, metformin, if somebody's on metformin, it should be stopped when kidney failure is present or when an IV contrast is going to be used, unless it is an emergency. There again, metformin is to be stopped when kidney failure is present or when an IV contrast is going to be used, unless it is emergency. Some of the side effects with metformin are nausea, vomiting, and diarrhea and bloating, but they usually do subside over time. So a new patient should be educated on that, because that would be a reason where they might not be compliant. So letting them know this can occur, but it usually does go away. Glipizide is notorious in causing hypoglycemia. So glipizide, you should really watch to make sure the patient is educated on, let them and their family know what hypoglycemia looks like, and be prepared with treatments available. Levemir produces decreased thirst, so monitor the patient for hypoglycemia as well as renal failure, because if they stop drinking, they have a higher risk of causing their kidneys to start malfunctioning. One of the big things, if somebody works out, they should actually do their injections in their abdomen, as this promotes better absorption and distribution of the insulin, but they still should rotate it. Insulin pens make it easy for patients to administer medications. They dial in the dose. Always mix clear to cloudy again when mixing insulin. Instill air into the clear, then the cloudy, and make sure you get the bubbles out. Do not give grapefruit of any kind to the patient who is taking Prandid. Once again, no grapefruit, citrus, especially grapefruit of any kind, to the patient taking Prandid. That's a grapefruit drink, grapefruit itself, nothing. Grapefruit salad. Meglitide is also notorious for causing disease. So you want to make sure you watch all of those. So that is pretty much it for diabetes. Some of the key things I do need you to remember, along with your notes. Okay, I hope this helps, guys. And we're going to stop.